Thank you, Peter. I'm just gonna try to get my screen share going. You guys able to see that screen?
Yeah, it's great.
Okay, perfect. Okay, so thank you for inviting me to present my research program. And as with many hospitalists and researchers on this call, my research really extends beyond one topic. However, today I'll just be focusing on antibiotic stewardship. So I have no conflicts of interest to disclose, but I would like to acknowledge the Agency for Healthcare Research and Quality, which supports my work through a Career Development Award. And then just to give you a high level roadmap of where we are going. So I'm just going to first talk about antimicrobial resistance and the current landscape of that, as well as a few stewardship principles. I'll then kind of talk about a few research projects that I've led in this area, and then some lessons learned along the way. So antimicrobial resistance and stewardship. So antibiotics are finite resources, and the drug development pipeline is relatively limited with many gaps. And the bacteria themselves are smart. And the development of antimicrobial resistance is a direct consequence of antibiotic use, with resistance in many cases outpacing drug development. An example of this can be seen as early as 1945. So this was only 17 years after the discovery of penicillin. And Alexander Fleming is describing antimicrobial resistance in this quote and recognizing that it is a threat to human health. Fast forward to 2019, and the CDC reports that antibiotic resistant bacteria were responsible for approximately 2.8 million infections and nearly 36,000 deaths in the US annually, with 224,000 infections and 12.8 thousand deaths secondary to C. difficile alone. So clearly a national and global problem. And while bacteria are smart, there are a number of factors that we control that contribute to the development of resistance. Specifically, inappropriate antibiotic use contributes directly to the development of antimicrobial resistance, as well as to adverse events and unintended consequences of the drugs themselves. So according to some estimates, nearly 30 to 50% of antibiotics that we prescribe for hospitalized patients are inappropriate. And in a study by Tribble, which looked at 32 children's hospitals, nearly 26% of children received one or more suboptimal antibiotic. And the most common reasons for that were bug-drug mismatch, extended surgical prophylaxis, broad-spectrum empiric therapy, and unnecessary use. And what's important to recognize is that utilizing common ASP principles, approximately 46% of these prescriptions would not have routinely been reviewed or intervened on. And so I think this really highlights that ASP, or antimicrobial stewardship, is a responsibility for all healthcare providers. And so what makes antibiotic use appropriate? Well, antibiotic use involves, of course, choosing the right drug, making sure we have the right diagnosis, and then choosing the lowest effective dose for the indication, making sure it's the most effective route of administration and for the shortest amount of time. And so these are some principles that will kind of carry throughout some of what I'm presenting today. So on to our research agenda. So, sorry, I'm trying to move windows and failing. Okay, so the first study that I'm going to discuss was published in the Journal of Hospital Medicine, and the initial motivation for this work really stemmed from recognition at my local institution that the institutional antibiogram really supported use of cefazolin as empiric therapy, and yet most children at our hospital were receiving third-generation cephalosporins, particularly ceftriaxone, to treat UTI. And so I had a suspicion that this, of course, permeated other hospital practices as well. And so the objectives in this study were to describe initial narrow versus broad spectrum antibiotic use for children hospitalized with UTI, inclusive of pilonephritis, and to explore whether initial narrow spectrum antibiotic use, so that's empiric antibiotic use, was associated with different outcomes. And for our purposes, narrow spectrum was defined pretty narrowly as ampicillin, amoxicillin, cefazolin, and cephalexin. And so we conducted a retrospective study using the Pediatric Health Information System database, which is a database of 40 US children's hospitals. And we additionally supplemented the phys data with institutional antimicrobial susceptibility data. And so in this study, we identified over 10,000 hospitalizations for UTI across 39 children's hospitals. Approximately 95% of encounters demonstrated initial broad-spectrum antibiotic use, with only 5% of all encounters really receiving empiric narrow-spectrum antibiotic use. And so in this figure, we're showing hospital-level variation in narrow-spectrum antibiotic use, and along the axis, each hospital is represented with a gold bar. And you can see that use ranges from 25% to really under 1%. And the dots on this figure represent hospital volume of cases, of UTI cases. And there is some correlation, or at least inverse relationship between hospital volume and narrow spectrum use. So those smaller volume centers tended to use more narrow spectrum therapy, which I thought was pretty interesting. So when we kind of incorporate that antimicrobial susceptibility data that we got from looking at the antibiograms, we got this figure. And so the blue bars on here are the percent of cefazolin susceptible E. coli within an institution. And those are plotted directly next to their percent of narrow spectrum antibiotic use. And you can see that there's a pretty big discrepancy, at least in terms of susceptibility versus use. And if you impose a 80% threshold of acceptability, which we commonly use for other infections and which is generally pretty acceptable for UTI management, we'd find that many hospitals could reasonably have applied or utilized cefazolin as empiric narrow spectrum therapy, but use was very low. So then when we move forward and we examine outcomes, we see that those who were prescribed initial narrow spectrum antibiotics had shorter lengths of stay and lower costs compared to those that received broad spectrum antibiotics. And when we focus in just on those with severity of illness 1 or the least severe cases of those who were hospitalized, the results are the same. And so what we really found here was there's widespread broad spectrum antibiotic use in children's hospitals in the US. There is low overall use of narrow spectrum antibiotics, but there's still a lot of variability among hospitals in who's choosing to use empiric narrow spectrum therapy. We also found that many hospitals had that greater than 80% susceptibility to a narrow spectrum agent. And that narrow spectrum antibiotics were associated with reduced length of stay and cost without evidence of differences in revisits or readmissions. And so this really highlights an opportunity for stewardship to improve prescribing and really address the gap of that narrow versus broad spectrum therapy. And so now what? So what does one do when they have collected 40-something antibiograms from across the country? Well, naturally, one decides to transcribe, standardize, and combine them, right? Like that's the natural next step. So that's in fact what I did. And I basically combined all the data across all the different hospitals into one aggregate gram-positive antibiogram and an aggregate gram-negative antibiogram. And then we also performed some regional comparisons using some simple logistic regression modeling. And so this work has been accepted for publication in JHM, but it's not yet available. But I'll just highlight some of that data for you today. So of the 51 phys hospitals at the time, we were able to collect antibiograms from 46 hospitals. And this data was representative of all 4 regions of the US. So we had 6 hospitals in the Northeast, 15 in the South, 11 in the West, and 14 in the Midwest. And here I've just provided a little bit of data that kind of coincides with CLSI recommendations. So CLSI is an organizing body that generates recommendations of how to display or how to put together an antibiogram. And so recommendations include only reporting organisms with more than 30 isolates. And so we found that only 22% of hospitals adhered to that recommendation, and 78% of hospitals reported at least one organism with less than 30 isolates. We also observed that just over a third of all hospitals generated a urine-specific antibiogram, with another third reporting a few individual bug-drug combos, and the remainder had no urine reporting. And then finally, we observed that 5 to 10% of hospitals generated an ICU-specific antibiogram or a NICU-specific antibiogram, while nearly 30% generated an ED-specific antibiogram. And this is important just in terms of targeting therapy based on the population of interest. And so I'm not going to present all of our data around this topic, but just highlight some of the gram-positive data that we have. And so within this table, each row represents a bacteria and each column represents a drug. And for ease of presentation, I've added some stoplight colors. So I apologize if anybody has is unable to distinguish red versus green here, but just for ease of presentation, I've added it. So the dark green color represents susceptibilities above 85%, 75 to 85% is the light green, yellow 60 to 75, and those with susceptibilities under 60% are demonstrated in red. The gray cells represent no data or insufficient data, so that would be less than 30 isolates, which is the recommendation. And by applying this color scheme, we can really see that most gram-positives are susceptible to linezolid and vancomycin, whereas erythromycin is a poor drug for most gram-positives. And this here highlights the number of isolates that we're looking at. So across the 39 centers, there are tons of Staph aureus. So there were over 53,000 isolates that contributed to that susceptibility reporting. However, for Enterococcus faecium, there are only 68 isolates in total. So you can imagine that at any one given center, there were insufficient isolates to be able to report Enterococcus versus that doxycycline. When we focus just in on the Staph aureus, here, we found that it was the most frequently reported gram-positive bacteria within institutional antibiograms and across all centers. Oxacillin susceptibility was 73.3%, and clindamycin susceptibility was 79.4%. And so we were able to compare this result to some historical data from Tama et al. In 2013, and we see that oxacillin resistance has decreased over time, highlighting a shift here in the US towards increased methicillin susceptible Staph aureus infections over the last decade. And then within our regional analyses, and again, this is just an example of what we performed, we see that susceptibilities were generally similar across regions of the US, with the exception that susceptibilities to oxacillin were lowest in the South and highest in the West. And this is not surprising given the historical distribution of increased MRSA in the southern states. So the take-homes from this work are that really provided an updated look at regional and national trends in pediatric antimicrobial susceptibility using multi-institutional data. And encouragingly, we observed some static trends for a majority of bug-drug combinations over time and across regions of the US. But within the study, we see how aggregate antibiograms can offer advantages in terms of guiding empiric antibiotic selection when data is not available locally. But they also can serve as important tools for non-children's hospitals that have these low patient volumes and can't produce a reliable pediatric antibiogram. So what does one do when they want to implement change? Well, you got to talk to the people, of course. So I'm clearly being a little dramatic here, but most of my early research was focused on use of administrative data, and the next project I'm going to describe represents my journey into qualitative research. So this last study is really focused on describing factors that influence prescribing diversity. And when I say diversity here, I really mean antibiotic variation. And so why do some clinicians prescribe more similarly to their colleagues while others prescribe different antibiotics? And it's important to acknowledge that not all variability is bad, but some variation in prescribing does contribute to that inappropriate antibiotic use and deviation from best practices. And so that's really kind of what we're trying to tease out here is just what are the many factors that contribute to prescribing variation. And so for this study, we conducted semi-structured virtual interviews with 26 pediatric hospitalists from children's hospitals across the US. Interviews lasted about 45 to 60 minutes. And of course, we did all the good things of transcribing, audio recording, proofreading. And then we performed a content analysis using the social ecological model. And so the we're really kind of at the step of continued analysis because, as you can imagine, with hour-long interviews of 26 participants, we have a lot of data to dig through. But some of the most important things that we found so far, and I think are really cool and representative of our field, is that hospitalists overwhelmingly self-identified as being frontline stewards and teachers of antibiotic stewardship. But they exist outside of the formal ASP team, as highlighted in both of these quotations. And I'm not going to read through the individual quotations just for simplicity today. And then in terms of prescribing similarity, what we found was that collegial stewardship relationships are having collaborative conversations with our stewardship colleagues, our ID colleagues, really made hospitalists want to work with them and to be, I would say, more align their practice with what their colleagues were recommending. And so that was a promoter of similarity. Other promoters of similarity in prescribing were cohesiveness of the hospitalist group and generating shared mental models. And those two concepts are kind of related in that having group conversations or conversations with your colleagues, as well as having vetted information, order sets, clinical pathways, or guidelines, all of that information together made people want to prescribe according to that guideline or according to that pathway. And so that was a promoter of prescribing similarity. On the opposite end of the spectrum, so factors that contributed to increased variability in prescribing included having learners on the team and trying to promote learner autonomy, as well as some factors related to the system itself, including the EHR. So in terms of promoting learner autonomy, I think this first quote really highlights that providers learner to prescribe something, even if it's not the most optimal antibiotic, as long as it's something reasonable. And that's to allow them to learn in the process. But that is in and of itself contributes to variability in prescribing. The other factor is just the ease with which we can access resources on the fly. So at least here in the US, and I'm not sure how it is for you all in Canada, but there's many different EHRs. How you access information and get information is very different. Many of our prescribing resources are either textbook resources or they exist outside of the EHR. And so to access things is just clunky, it's non-intuitive, and that can contribute to differences in how you prescribe if people are accessing different resources or in a different manner. So take-home messages from this work is really that hospitals self-identify as stewards but are often not engaged in stewardship activities. Antibiotic prescribing is complex and influenced by many non-patient factors, so many interpersonal, systems-based factors and organizational factors. And creating a shared vision and mission of stewardship by engaging hospitalists in stewardship activities could enhance, I think, prescribing interventions. So moving on to lessons learned. So there are so many opportunities to improve clinical practice and advance antimicrobial stewardship. In the words of one of my colleagues, question everything. So what evidence supports a given practice? What evidence supports a given antibiotic duration, a given diagnostic test? Is there alignment between clinical prescribing and local antimicrobial susceptibilities? And then finally, engage all relevant stakeholders. I think that's one aspect that's lacking at many of our centers right now is ASP is run by ID and they are brilliant people, but they're not always engaging with the relevant stakeholders that are involved in making the clinical decisions up front. And I'll sort of return to the slide and I'll leave you with the thought that there is a never-ending limit to the questions we can ask. And each of these stewardship moments can serve as an excellent starting point to plan or to conceive of future research questions. And thanks.